Hello, 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 everyone, and welcome to another episode of Ask the Doctor. We are with Dr. Syed Alam out of Battle Creek, Michigan. He is a vascular surgeon. Welcome, Dr. Alam. You had an emergency case today. You're joining us from your car on your way home. Very long day for you, I can imagine.
Well, no, thank you very much for having me. This was not long. It's typical. When we get home before it's dark, it's a typical day. It's not bad.
So, for the patients that are here, they're always wondering, do I have an emergency? Is my case an emergency? Taking the case that you just performed, what necessitates an emergency in your mind?
When someone is losing a leg, someone is losing their life, obviously, those are the type of things which are considered emergencies. Actually, you guys won't believe it. My emergency case right now was an emergency amputation because this patient did not come to the hospital when she needed to come to the hospital, came in very late. CK, which is a marker of how the muscles are doing, was 18,000. It's that high when you have burns or you have other. We looked at it. There was no way of saving her leg. And I came in, and because she was getting sick because of her dead leg. That's why we ended up doing an emergency amputation on her. So
Sometimes it can be it's either the leg
ended
or
up doing
the
an
life.
emergency amputation, right? So we had to save her life. Unfortunately, we lost her limb, but sometimes things work out. But I
For the
think
most part
she's going to be. Mhm.
with these types of
Go ahead.
cases, you
Mhm.
said that she actually waited too long. How long, and this is a loaded question. I know it depends on the person, but how long is too long in a case like this? I mean, she waited and she waited. And I always wonder myself, how long, why do you wait that long when your leg is obviously degrading? I was in the Netherlands and there was a case where a patient actually came in with a bag wrapped around her leg because the smell of the gas gangrene was so bad that she couldn't stand it. And we are like, why did you wait that long? And she just said she was embarrassed by it, wasn't sure what it was until it literally got to the point where it started smelling. And even then, she waited yet another week before she went to the doctor.
Wow. It's very difficult. Sometimes there are social issues, right? Sometimes there are patients who cannot travel. Um, but for the most part, I really cannot tell you why patients wait that long. Like you said, sometimes it's an issue of embarrassment. Sometimes it's an issue of, oh, I don't have insurance, or my copay is too high, or, from the standpoint of when to see the doctor, is as soon as you feel like the patient feels that it hurts with activity, they should come and see the doctor so a plan can be made. They're not going to need surgery when it hurts with activity, but a plan can be made, a follow-up system can be created. They can be placed on antiplatelet medications, other, like cholesterol and diabetes and all other things can be managed. Now, if they don't come to see the doctor when it starts hurting with activity, they have to go and see the doctor as soon as it starts hurting at rest. If at some point the leg does not let you go to sleep or wakes you up from sleep because of pain, you need to be in an office.
It's interesting. We just had a patient that I was talking to a few moments ago, whom we are featuring in this weekend's Save My Piggies episode of our radio program, The Heart of Innovation. And Rose was telling me that she went 4 years with her primary care doctor and also confirmed by her gynecologist that her vitamin D was low. And because her primary care doctor said, you're experiencing these debilitating cramps because your vitamin D is low. When she went to the gynecologist and she said the same thing, your vitamin D is low, she was like, oh, so the reason I'm still experiencing these cramps and I can't walk across my 93-foot house without having to rest before walking back across the house. It's because of the vitamin D. She didn't bother to actually go get further assessment. She didn't even know that it was possible. So she went 4 years, and then she was diagnosed with lung cancer. And it wasn't until a year later, where in follow up to her lung cancer surgery, where they removed the upper lobe, the doctor, her pulmonary doctor, said, "Do you realize you have some artery blockages in your abdomen?" And she was like, what? I didn't know this." And that's when she finally went to the doctor, and she got some relief. She realized that there was something that people could do.
And that is a scary story.
Do you see that happening a lot, where patients get to you too late because their primary doctor brushes off symptoms? And I use the term brushes off lightly, misdiagnoses their symptoms as diabetes, diabetic neuropathy, sciatica, vitamin D. That's a new one on me. I had never heard that before. Fibromyalgia, arthritis, all of the above.
Kim, it's a very interesting, and I think it comes with where you practice and how you practice. At least in our area where our practice is, we spend a lot of time educating our primary cares. We don't only try to educate the patients, we try to educate the primary cares as well. But even things like this happen. 4 years, I'm not too sure, but I recently saw a patient who was told by the primary care doctor that the problem is the patient was sent to the neurosurgeon. The neurosurgeon tried to feel for pulses, could not feel pulses in the foot, and sent them to me. And the patient had aortoiliac blockage. But sometimes these things get diagnosed late because people are just not educated about what they have to do and what they have to look for. Uh, Unfortunately, that's a problem all across the country. The only thing we can do is try to educate as much as possible.
And that's true. I want to get to some of the questions. We have quite a few people that are joining our live studio audience, and our amazing producer Josh is checking on YouTube as well. And we have our friends here, Marcia and Marie, that are checking our Facebook page to see, and they're adding in some questions that are coming in on there as well. But I want to start with Heinz, because Heinz is right here in our live studio audience, and he does have a question for you. Heinz, go ahead.
Hi, doctor. Question for you. When you do surgeries in general, any vascular surgeon or whoever that might be, and you remove plaque from a person, does that plaque get studied to see what's in there?
Yes, it does. And
where does it go to?
So it goes to pathology.
Okay.
And in pathology, they look at it. Most plaques are very similar, right? Very, very similar. Sometimes there is an extra calcium layer. There is a rupture within the plaque. So they comment on it and they let you know. It's 100% of the times by law, when you take plaque out, it has to go to pathology for evaluation.
Okay, thanks.
All right,
That's pretty cool. And Dr. Alam, do you want to talk about what are the different types of plaque that you can remove from an artery?
I mean, it's atherosclerotic plaque, right? They're all very similar. They all have the same layers that we have talked about multiple times. The difference is sometimes plaque can be extremely calcified, which means that you guys know what calcium is like, right? So it's almost like having brittle bone inside the artery. So the arterial wall, instead of being soft and strong, becomes hard and brittle, almost like chalk. So that is very high level of calcium when you have that. Sometimes, like I mentioned previously, there's a rupture within and that will show us almost like small clots inside of the plaque. Does that make sense?
It does. Thank you. Everyone always asks me, because when I say, "Hey, well, what type of plaque is there in your arteries?" Because there's a big difference. And if you just have fresh clot versus thrombotic material versus calcium, as to what might be really going on and the possible treatment options that we can discuss. It also can dictate whether or not your vessel might reocclude much quicker. If you're someone who doesn't have controlled clotting and you keep getting fresh clot, fresh clot, fresh clot despite your medication, that's an entirely different story when you're talking about mitigating your risk factors, correct?
Absolutely. So plaque and clot are two different things,
Yeah.
right? So plaque will form over years or decades, right? And it's based on lifestyle, genetics, smoking, hypercholesterolemia, multiple factors, hypertension. Clot can form because of a hypercoagulable state, which means that you are prone to forming clots, which is generally an acquired state because of smoking and other risk factors. Sometimes there's a combination of two, which are called acute on chronic, which means that you had a that had already narrowed your artery, and now you have formed a clot inside that plaque, so that 70 plaque that was not an emergency becomes an emergency because a clot comes and blocks it 100%.
And that's one of those situations, if we're going to go a little bit full circle to what you were talking about in the beginning of the conversation with your emergency situation, this is one of those cases where that can turn very quickly. If you have an
Oh
acute
yes,
clotting situation, that leg can go gangrenous just like that.
yes, within hours actually.
And so, how does a patient know if it's something that they need to get to the emergency room and they need to get that clot sucked out? I mean, most of the clot, we were talking to a Dr. J. Matthews out of Florida, and he said most of that, if you get to the hospital within a few hours and they handle an acute clotting situation according to society protocols and get on it and get that clot, get on a heparin drip, get in a catheter, delivery of clot busting drugs and or thrombectomy, and get in there and start treating that soonest, you can save the leg. But there are still too many situations where a patient is still sitting on the gurney in an emergency room waiting and waiting and waiting, and nothing is done till the point. And the waiting game, it is literally just hours. They're waiting to the point where the only option by that point is amputation. So how does someone advocate for themselves if they see this happening?
Well, it's when someone develops an acute pain, which means that pain just starts all of a sudden. It's a clot until proven otherwise. And when patients go to the hospital, I mean, I will talk as we because I could be a patient tomorrow as well. Go to the hospital, we have to demand that we get a CT scan or an ultrasound very quickly. And if there is a clot seen, so now if there's an arterial clot seen, within 6 hours, that's the window, generally acceptable window, you need to be mobilized, which means TPA is the drug that we use. Some people take that 6 hours up to 24 hours, especially if there's an old graft or an old stent that has been lost. So people use the thrombolytic therapy for that long. And it works like magic. I've seen people get better and get out of the hospital in less than 24 hours. Well, less than 4 hours. Like they do it for sometimes stroke, because some strokes happen because of clots. And what they do is patient goes to the hospital. There is a society protocol that they need to be started on. They need to have a CT. If there is no bleeding, they need to be given the clot busting medication. And when that happens, they usually are home within 24 to 48 hours. So we have the technology available. The problem is that most people who have leg problems have a lot of chronic PAD problems as well before the clotting happens. Now, in patients with chronic PAD problems, you can suck out the clot, you can dissolve the clot, but the problem stays. Sometimes sometimes their operations end up more complicated than you want a clot removing operation to be because of the chronic problems that are system in addition to the clots. Does that make sense?
It does. One of the vascular surgeons that we work with, we had a patient that we sent to her, and it was one of those clotting situations where she describes it as she poked the beehive and the clots just showered all the way down the leg. And she said the next time she has one of those clotting situations, she would probably stage the patient a little bit more to and figure out how they were going to potentially mitigate the risk in case if they she knew it was a clotting situation. I just wondered if you've dealt with any situation like that so that, there aren't that many. What about 10% of doctors have your skill in the US? Maybe there's more now because I think the word's gotten out in the last few years that more and more people are adopting the more advanced tools and techniques. Have you dealt with a situation like this? And what would be your best advice if a patient is going into a doctor where they don't know what their skill set is and they know that they have some clotting going on? Can they ask, hey, do you have a filter that you can use? Can you try a pedal approach? Will a pedal approach instead be better than going down from the groin? What are your thoughts? And I know that you as a doctor and other doctors are not used to patients asking these critical questions, but we've had a lot of success where patients are more educated. And when they do ask these more technical questions, their legs are more likely to be saved in our experience.
I'll tell you this. If somebody is ready to do a clot busting medication or a catheter placement, I generally leave the decision to the operating doctor about access. So if they feel that the clot is better removed coming from the groin versus coming from the ankle versus coming from the arm, I let the person who is going to do the procedure make that decision, especially. But the one thing you need to know as a patient is, are they proficient in what they're doing? Right? So if they have been doing it for a long time and they know what they're doing, then I would let them choose, especially in an acute emergency situation. I would let them choose.
Well, of course, in an acute situation, you have no choice. I mean, you just
You
got to
have no
let them do
choice.
their thing. You chose the hospital, right?
Right. You just let them choose what they're doing, and you can ask as many questions as you want, but you let them choose what they're doing, because in an acute situation, every doctor makes sure that they're doing what they're comfortable. You don't reinvent things in an emergency, especially. And when it's a limb-threatening emergency, like I can give you an example. I know a lot of wonderful vascular surgeons who don't do this clot busting medication. And what they do is someone comes in with an acutely thrombosed or clotted off leg. They will take the patient to the OR, give them general anesthesia, make a little incision in the groin, go down to the blood vessel and pull the clot out with their hand and close the vessel. And, it's a 1 hour operation. It's a very good operation. It works really, really well. But that is how I want to do it. So the goal is being able to save the leg. There are different modalities that can be used. They all have good results for the most part. But I think when you are in an emergency, my take home point would be go with what is available to you and have faith in the doctor that is working on you at that time, especially if they know
Well, I
what
mean, if there's an emergency, but I'm saying this is one of those things that there was a lot of chronic clot in there, and there was some mix of some acute clot, and she wished that she had gone in and gone both ways, had a filter placed below to catch all that clot just in case she
And
poked the beehive.
these are arterial clot I'm talking about, not venous, right?
Yeah, arterial.
Yeah. Yeah. So this is a completely different scenario, right? This is
Correct.
a acute / chronic problem, and you would need to do a laser atherectomy, give some TPA. There must be a filter lower down to make sure that it doesn't embolize. So that it becomes a very complicated endovascular scenario.
Very, very complicated. Yeah, she said she's like, I wish I would have just sat down before and literally got a filter placed and everything else before I went in and poked the beehive, because it just immediately just showered. It was just unreal, just trashed the foot. We do have Mark who's writing in from YouTube, and he's asking about nattokinase. I don't know how much you're familiar with nattokinase. That's that traditional Japanese fermented soybean that there are folks out there that say that it can have the potential to dissolve clot.
My I don't know anything about it. There is all the drugs that we have are called kinases. Like there's urokinase, drug that is used, but I'm not sure that it comes from a Japanese soybean. Maybe it does. I am unaware of it. And the drug most commonly used these days is called TPA, tissue plasminogen activator, and it's based on urokinase.
That's interesting. That would actually be interesting to go look at and see because a lot of things, for example, your statins are based on red yeast rice. And so
Yeah,
a lot of them are coming from, they're not necessarily synthetic. They come from natural means. At least that's where they begin, and that's where the active ingredient begins. So I definitely want to look that up. Or if anyone who is watching right now wants to look that up, that would be really interesting to bring into this conversation just
yeah.
for an FYI. We also have a
I would
question
love to
coming
know.
in. Yeah, that would be great, Mark. If you have a chance to Google that. He also, while Mark, while you're Googling that, I'll ask Dr. Alam here about the keto diet. Do you have a lot of patients that are on the keto diet, and whether you've seen it be a success for PAD? Before you answer that question, we do have Dr. Michael Dansinger, who wrote the famous diabetes reversal program, as well as the Tufts, as well as the famous comparison of all of the different cardiovascular and vascular diets. And you can see that out there. But Dr. Danziger is live every single Monday at 3 p.m. Eastern time, right here on the YouTube channel, youtube.com/at the way to my heart. And he can answer any questions you have about diet, nutrition, as well as supplements. So that's just good to know. But I'm just, curious from your standpoint, Dr. Alam, if anyone's come in and said, oh my gosh, I'm on the keto diet. I lost all this weight. My diabetes is fixed. We're good to go.
Zero. In my area, when people want to lose weight, they go on Ozempic.
That's true too. And that's a great
Yeah,
place to start for so many people. So many people say that that is really a game changer for them. They think that these GLP-1 drugs are something that it's really going to change the game for diabetes.
yeah.
And Lisa is asking, she says, I have pain as throbbing in the right ankle, started with tingling and super sensitive when she touches it. Um, it does change to a dull ache and travels to the foot, and she is not yet diagnosed with PAD. Does this sound like PAD?
It
I know we don't
does.
have more information, but it does.
Based on what she told us, at least needs to be checked for PAD, and she needs to be checked by someone who knows what they're doing. I would recommend an ABI exam and a physical exam to see if the pulses are present. One more thing you can ask her if she's live, is her foot cold?
That's a good question. And we will post that if Marcia, who's here, and Marie, who's here, is handling our Facebook and taking a look at that. That's a good question. If you can um, reply to her message and just ask her if her foot's cold, but that Dr. Alam says she should, in fact, be checked for PAD because the symptoms are sounding as though that might be the case. So it's good to get checked, but he is following up asking, is her foot cold as well? And that temperature change between the 2 feet is a really good indicator as well. And let's see what other questions. Oh, we have Judy who's here. Judy, do you want to ask your question? You can go ahead and unmute.
There we go. Well, I have so many questions because I just got diagnosed about 2 weeks ago and I'm scared to death. But I
Well, it's good you're
have,
here.
yeah, I have two hammer toes and also, I didn't write, a fungus that I've had for 35 years on a big toe, and I'm diabetic. So is it likely that these toes are going to be amputated?
No, I don't think so.
Okay.
Um, you know, you said I there was a problem in what I was hearing. You said that you were recently diabetes, or you were recently diagnosed with PAD.
PAD.
PAD. And how did they diagnose you?
Well, I was having difficulty walking all of a sudden. So I had that, I don't know the technical name for it, where they put electrodes on my toes.
Oh, I got it. Okay, good. So now, are you following up with the doctor that did it?
Uh, he said he would follow up in 3 months, which I don't really feel is sufficient because I have so many questions. Like, now I'm feeling pain in my um butt, my buttocks. Um, and I learned that we have an aorta in our stomachs. I didn't know that
Yes.
either.
So the aorta from the upper part of the chest, which is where it comes off the heart, and it goes up to the level of the belly button. Uh,
Um,
and at the belly button, the aorta divides, and one side to each leg. Um, do both sides of your buttocks hurt when you walk, or just one side?
uh, both, both. It feels like a sprain, like I sprained it.
Yeah, you need to call your doctor's office and tell them that you're having all these problems. You may need a CT scan.
Okay. Because only one leg was diagnosed with PAD.
The other
So
one was
I'm
not.
curious.
No, the other one was not. So I'm wondering why. And one foot gets extremely cold, like it's in an ice box.
Do you have any other comorbidities? Anything else that, because doesn't that sound, I mean, was this something that was acute that's, or something that has come on over the course of years?
Acute. I-
That seems surprising to me, Dr. Alam, and we have seen this quite a bit where they've ended up in a situation like that where there's like this type of acute situation where they suddenly, just suddenly can't walk and it's just progressively worse and they get brushed off and there's fresh clot building up, building up, building up due
Oh, in the
to,
aorta, right? Oh, absolutely. That's why I said she may need a CT scan. Um,
yeah.
Okay.
Judy, you can go
Yeah.
ahead and message KYM at padhelp.org, or we have our Leg Saver hotline. You can call after we're done with this. I'll make sure to answer. There's other people that'll answer, but I'll answer if I see you're calling in. That number for the Leg Saver hotline is 415-320-7138. That's 415-320-7138. And I think if someone can put that in the chat, that would be great. If you call, then we can help you if we know where you're located, get you, someone will get that CT scan ordered for you.
Okay.
Because that is concerning, the symptoms and that they're progressing like that. That to me is a little concerning, and especially that Dr. Alam says it's concerning as well. So it might be something that we can talk to I might even know your doctor, that we can get on the phone with them and let them know what you're experiencing. Sometimes they just don't know, the message just doesn't get to them of exactly what's going on. And all of these doctors are tapped. They're at the limit. They have so many patients. Everyone seems to be coming down with PAD these days, which I don't know, Dr. Lum. I'm not sure if it's literally that there are more cases, or it's just that, as you were saying in your area, that more primary care doctors are getting more educated. The societies and all of the campaigns that are happening, whether it's the American Heart Association, ADA, ours, which is the Global PAD Association, Society for Vascular Surgery, or SCI, or all of the above, they've all been putting out some pretty robust campaigns that I think are helping to raise awareness, which means that maybe people are getting diagnosed sooner, which would be great.
Hmm.
That's part of the thing, but I think the number of PAD patients is increasing. It's multifactorial, obviously. Uh, our eating habits in this country are horrible, and that is the number one reason. And younger people are getting diagnosed more and more because there is more education. Like you said, multiple societies, people like yourself, uh, you know, social media, all of these things play a big role in people getting educated earlier.
Yep, I think that's true. Are there other questions from the live studio audience here that we can get to before I get into some deep questions, which I had mentioned to Dr. Alam prior to starting this video? I know that Marcia had the same question that I did, so I think actually we're gonna start there, because in the past few weeks I've had 3 cases where someone has called the Global PAD Association's Leg Saver hotline, where someone they loved was on deck for amputation. Doctors saying that there's nothing that can be done. In each of the situations, the patient um, was not in a good way. A lot of other things going on. I remember one of my mentors is Dr. Craig Walker, and he always says that you never see an unhealthy leg in a healthy person. So you really do need to double check all of these other things, not just the legs. And I'll give you one example where we still have a patient just holding on. The wife is refusing to put her husband in palliative care. He went in for a procedure. During recovery, he ended up with a blood clot that went up to his brain. He stroked out. They had to bring him back to life. He ended up on life support. He had vasopressors because his blood pressure kept crashing. And suddenly, once he got out of the ICU, it seemed that his legs started turning. And I've seen this over and over again, especially for patients that have been placed on what's called an ECMO machine, the artificial lung, because that can throw clots. But then you have the
Right.
vasopressors, right? And you're going to describe this better than me. But just I'm setting it up for the patients with that the pressors that raise your blood pressure, and they do this by maximizing blood flow around your organs, and sometimes that's at the expense of your peripherals, your legs and your arms. And so we've had a lot of patients come to us with not a traditional presentation of PAD. And uh, they're like, oh my gosh, how can we save their legs and their arms? And what doctors have told me is the arteries look very, very different in those situations, and you can't just revascularize them in that same way. In many cases, it makes it a lot tougher. And if the patient is not a surgical bypass patient where they can bypass some of the damaged areas, um, it's best just to let them, just go on to palliative care and just live out their life the best that they can. But this one patient is basically unresponsive, and I finally got the hospital and the vascular surgeon and the primary care, the hospitalists were like, you need, please help us convince the wife that he needs a feeding tube. We need permission to put this feeding tube in. We can't even think about his legs until we know that he's stable. She was just so worried about the legs, and I see that often. I mean, I'm not even sure where the question is, but where do you draw the line when it comes to saving the legs in patients that are very sick? We had another patient in Virginia, and he was on dialysis and had a wound that wouldn't heal. They did end up making the choice to cut off one leg, but when he was recovering from that, they ended up saying your other leg is now turning. And so now we're going to have to take the other leg. And he said, you know what? I am done. I wish I didn't even have the first leg, taken. I wish they would have told me before that it wasn't going to make a difference. And I wish they would have just let me go. So I'm just curious your thoughts on if you can unpack all of that.
Well, thank you for understanding that unpacking that is a big deal because
Yeah.
every patient situation is different, right? There is um, principles that we as surgeons have to always adhere to. And the principles of surgery can never be changed, no matter who the surgeon is. The principle of surgery is life comes before limb. And that is just a very, very basic principle that we have to follow every single time. Now, on that, there are certain, it's usually family members. It's, in my experience, never the patient. It's usually family members who want to just hang on to the idea that it can be saved and someone can get back to normal. The
Yes.
problem is the patient that you described as being on pressors and ECMO and that person is never going to be back to normal. That is not going to happen. And that is something that the family needs to understand, and the doctors need to be able to communicate very well, especially if they are on multiple pressors with sepsis and elderly. It's just not going to happen. So that is one end of the spectrum. And I'll tell you this, every single time I have had to make a decision about taking a limb to save the person's life, I have taken the limb because it is the right thing to do. Even though my life revolves around trying to save limbs, but when it's the right thing to do, that is what you do. I'll tell you guys a patient story, and because it's very relevant to this discussion. He's a gentleman who's like 74, extremely active, all over the state of Michigan, goes to Florida to golf. And I've kept on telling him that you have to get less active. You're 74 years old, act like you don't act like you're 47. The man has had an aortic repair, he's had a bypass in one of his legs, and he's a vasculopath, but he's very active. So lo and behold, the gentleman was on his roof trying to clean his gutters after one of the snowstorms here in Michigan. He fell and broke his hip.
Oh no.
Went to the hospital in December, had a pelvic fracture that was repaired, everything was fine. Stayed in the hospital for 4 weeks, got a lot of pain medications and opioids, could not move his bowels, and resulted in a spontaneous colon rupture,
Oh.
which resulted in emergency surgery and a colostomy with sepsis and going on dialysis, which resulted in his bypass in the left leg going down and his left leg turning in one night. Then the trauma team called me because I was his vascular surgeon. I went in, he was intubated, he could not his decision. I've known the man for about 10 years. And we're not friend. He's not my patient. He's more like a friend to me. And his wife knows me very well. His daughters know me very well. His daughters are almost my age. So we all sat down and we decided that instead of me trying to save his leg at a time when his life is injured, I'm just going to go in and cut the leg. And it was a very difficult decision to make for the family. It was actually an extremely difficult decision for me because he was such an active gentleman. But his wife said something. She said, if there's someone who can come back from it, it's this guy. I said, okay. We did his amputation, and the man we did his amputation in early January. He came to my office recently. He already has his prosthetic. He's standing and taking 2 or 3 steps. He's already off dialysis, and he's going to get the reversal of his colostomy done by the general surgery team in May, is what he told me. And, he is the happiest man that there can be because we made a quick decision to do a primary amputation. Now, every person or every patient cannot have the same outcome and they cannot have the same decision making. We just have to follow the principles. And the principle is that there's actually two things here. One is life before limb, and there's a second issue. There's sometimes, you know, patients end up having hundreds of procedures sometimes, if maybe I'm exaggerating, but a lot of procedures. And the problem still remains, right? They may have ulcers, they may be in constant pain, and they may get a procedure every 2 weeks, every 3 weeks. I think at that time, sometimes a very serious discussion needs to be had about a therapeutic amputation, because amputations can be therapeutic as well. And when you do something like that, you have to make sure that the prosthetic team is on board, the physical therapist is the right person, the patient can actually get back on feet in 6 to 8 weeks. Um, but those are all the types of things, because you said this is unpacking of difficult questions, right? So there are times when amputation may be the preferred treatment. And the unfortunate problem is that there's a lot of doctors out there who don't look at the situation. They just look at a problem and they say, oh my God, this is a difficult problem to fix. Let's just cut the leg off. And I see a lot of doctors around here as well. And I hope that patients don't end up with doctors like that. And,
Yeah.
but, somebody, go ahead, sorry.
No, we have this situation over in one area that you and I are both very aware of, that we've become actively involved in, and we ended up with a patient that you talked to actually on Saturday from that area, and she showed up for one of our calls, and she is adamant that there is some serious racism with some of the doctors there. And I was going to ask you if you have, seen some of this, or is it just that there are doctors that just cut off legs, and in some of those communities, it just happens to be that they have higher populations of the African American, and they go to those doctors that just know how to cut off legs, and that's the way it is. I mean, what are your thoughts? I don't want to downplay her experience, because she feels, and I've actually experienced firsthand some discriminatory comments from a doctor. It was one of the reasons I decided to do what I do, because I had a doctor. We had this wonderful Black man that came into the clinic, and he was 50 years old, but he was with a cane, hobbling over. He looked like he was 85. And so I thought, oh gosh, this isn't going to be good news. But then he pulled up the imaging, and I've been in thousands of hours of these procedures, and I had just been in 4 procedures with that doctor earlier, and had seen him with ease open up these complex blockages below the knee and into the foot. So I thought, oh wow, no, wait, this is going to be actually good news. And he looks at the gentleman and he says, I'm so sorry, mister, we're going to have to amputate. We've already done it 3 times and it's just not working. So we're just going to cut off your leg. And the man burst into tears and he left. And legally, I can't say anything. I'm just a fly on the wall observing. And afterwards, though, I asked the doctor, I said, I don't understand. You did all these complex procedures earlier. That looked like a piece of cake compared to those. He said, yes, but he'll just block up again because, face it, he's a poor Black man from the projects. He smokes, he drinks, he won't take care of himself, he won't exercise. So, and this always literally rings in my ears. Why delay the inevitable? And that made me really sad. And so that just haunts me to this day. And it makes me realize that it is a reality in some areas.
Well, first of all, it makes me very sad as well. But it is a reality. There have been actually very good data written in vascular surgical journals about this discrimination, that there are certain communities that have higher risk of amputations. They have higher risk of early death. They have higher risk of early kidney failure. They have a higher risk of a lot of things. But it's very difficult to pinpoint it on one reason for that. It is eating habits, it is poverty, it is living conditions, it is smoking. Actually, it's a lot of marijuana use. The worst arteries I've seen and the worst plaque I've seen are in people who are daily marijuana users. Nobody has written about it, but people who smoke marijuana every day, they end up getting very bad PAD. Um, but in any case, there's multifactorial reasons. But yes, the one factor which we can combat is make sure that there is um, no discrimination, especially when it comes to patients and especially patients in need. Uh, I work in areas which are, some of those areas are extremely poverty stricken. And that is one of the most important thing that my staff is well aware of, that, you know, especially when the patient comes in and they look the worst, those are the people that need our most. But even then, they sometimes they have they make lifestyle choices that makes it difficult for them long term. But discrimination is certainly something that should not be tolerated at all.
Yeah,
And
no, I agree.
what you said, it really is sad that somebody who has the expertise to open things easily can just tell somebody, yeah, go away.
Yep. And that was one of the catalysts for starting the Global PAD Association. I looked at the doctor and I said, "Here's my card. I'm going to do something about this. You give him my card if you see him." And of course, he never did. Um, I don't I don't know what happened to the gentleman, but at least I tried, and I never went back to that one particular doctor in Louisiana. After that, none of my patients go to that doctor, but which is good. That's because that's pretty scary. um but you mentioned something very interesting, and I want to drive home this point before we get back into the amputations. I see we have another question coming in on that, because Science Direct came out with a study. I can't remember when, it was just a couple years ago, and it said that, disturbingly enough, they're seeing more 18 to 27-year-olds, I think it is, showing up in emergency rooms in critical limb ischemia, critical limb threatening ischemia. And they attribute it to um, partly diabetes and the early onset of diabetes, because of poor eating habits, a lot of changes in our foods, the addition of a lot of high fructose corn syrup, more carbs, et cetera, et cetera. You mentioned even before the poor eating habits overall, right?
Mhm.
And they also mentioned the increase in this particular generation in use of marijuana, thinking that it is safe. And I remember, especially being in Silicon Valley with the 20 somethings and a lot of the millennials, a lot of the entrepreneurs, it was the cool thing to all get together, and they would have their best idea sessions while they were smoking out. And I thought, gosh, when you burn something, it just makes sense. When you burn anything and you breathe it in, it becomes toxic. And I
Right.
was reading an article that said that smoking marijuana actually has more tar than nicotine.
It does.
How do we get that message out, Dr. Alam? I mean, just this, Mary Yost added that. It's so interesting that Mary Yost, she's a world-renowned researcher on PAD. She put it in her recent presentation that I saw at a conference in June.
About marijuana use and PAD?
About marijuana use and PAD. And she made that theory. She really thinks that there's a strong connection that should be studied.
I actually think you bring out a very good point. I think that, uh, I do not have the answer to that right now, but we can put our heads together and we can come up with some type of an educational campaign about marijuana. See, the problem is marijuana is one of those things that smoking used to be in the 60s. It's cool. And like you said, people do it. It's the cool drug for idea sessions. Uh, I think it's a cool hangout drug to hang out with friends, when you're younger, and get rid of it when you get older. But I think there's a lot of population. I mean, Michigan, it's legalized for I don't know how long. I mean, we have more pot stores than have, grocery stores.
In Las Vegas, they're on every single corner. And when my dad and I were just in Las Vegas, And I stopped by because one of the doctors said he should get the tincture to put under his tongue for some pain he was in. And I went to stop there. I can't tell you how many black Suburbans were with drivers were showing up there at this one, and they have a security guard out front. And how many people were just stopping there to go get their pot for their really fun weekend in Las Vegas. And I'm not talking about consumption, and orally, but I don't know anything about that. I'm talking about the smoking, the actual lighting it up and burning of it and breathing that in. That's what you're referencing as well?
That is the only thing I'm referring to.
Yes.
I know that the gummies and the oral marijuana is the number one reason for psychosis people now in the ER, because nobody knows how much pot is in a cookie. They end up having 5 cookies because it tastes good, and then get a sort of kind of an overdose, and they go in psychosis to the ER. I know that, but I'm just talking about smoking pot. I think that results in very bad PAD.
Good thing you and I should take that offline later, because I actually just wrote up something. We are writing a book on walking as medicine and kind of using that to ease into an explanation of PAD, all of the other risk factors. And one of the sections is on general smoking, but also on cannabis and its use and smoking of it and the impact and debunking the myths that are out there. And so I'd love to send you that part of the chapter and have you look at it. And then what we can do is I think that we can uh, break it up and we'll make a video on it, a really fun video.
Okay.
We just got done with one on diabetes. We're doing one on chronic kidney disease right now. And then we can make that our next one, where we'll focus on an awareness campaign on cannabis, because I think that would be really interesting to do. So we'll work on that together. But Marie is asking, what happens, back to the amputation conversation. And this is our Ask a Doctor series, so we can jump around. There's no method to our madness here, so everyone can just jump in with questions. I don't want to take up too much of your time, but Marie is asking, what happens if the patient tells you before surgery that under no circumstances are you to amputate their leg? Here's what my understanding is, then you can refute me. I hope you don't mind when I do it, because I'd love for you to, I like when you correct me or reaffirm what I'm saying, so I know how to direct people. But if you don't sign that consent form that says, hey, if this doesn't work, you can take my leg, they will still amputate if it is your leg or your life, no matter what. If they figure that, well, it didn't work, I couldn't fix your artery, but I'll wake you up, I won't take your leg, and we can have that conversation. And if you have time to go get a second opinion, you can go get a second opinion. But the reality is, if it's your leg or your life, they're going to take it no matter what. Like, that's your duty as a doctor to say, I have to do no harm.
Yes, but that does not happen intraoperatively. That decision, what you just said, say, Marie is my patient, so I'm going to use her name. So let's just say a patient is going to the operating room for a surgery on the leg, and the patient says, no matter what, you're not going to cut my leg off. Then that is what every doctor is obligated to do under law. Now, I can give you one possibility where they may not be able to speak to the patient. That is, something bad happens in the OR, something happens, and they come out of because nobody wants to do the amputation at the time when they're doing a bypass surgery or something, right? Because then it becomes 2 operations instead of 1. Let's just say there's a problem in the OR and you have the patient intubated and the patient is on life support, and you go to the OR and you go to the ICU. That is when the decision is made. If the patient is unaware, that means that they're going to be into, and the family will make the decision, and the amputation may end up happening 2 or 3 days later. This is like a 1 in a million scenario that I'm presenting. Otherwise, if a patient does not consent to a surgery, that surgery cannot be done.
Good. So I think that's making her very happy.
And I can give her one more example of that. There was a patient of mine, this is about 9 years ago, who had absolute gangrene of their leg. They came in with that to the hospital. There were three different vascular groups working in the hospital. Actually, two were in the hospital. One was outside who had privileges. The patient got opinions from all three. All three told them that they needed an amputation. They refused an amputation and they started getting septic. Then the ethics committee of the hospital got involved. And the patient ended up having an amputation.
Wow. But in that rare
But this
situation,
is
if
Go ahead,
there's
sorry.
a life-threatening situation, whatever it might be, they have to make an abrupt decision, even if it's rare. They would take the leg if there's an acute.
Generally, we do that after talking to the patient or the
Oh,
family.
still. Okay. So there's usually no situation like that where they go in, they can't do it. There was a complication, but there's no complication that bad to where they have to just cut off the leg right then. You usually have a few minutes. You can go and you can talk to the patient, or you can talk to the family if it is that, serious of a situation.
What my patient is concerned about, it's called paranoia. It's not going to happen. So,
Okay.
it's sometimes we get it as well, right? That somebody wants to cut my leg off. Maybe you have heard it multiple times from other surgeons that you should have your leg cut off. But the only way people get an amputation is with a consent. They may not like to give that consent, but sometimes have to give that consent to save their own life.
Yeah. That's a good way to put it. Marie says that she doesn't have to worry about it. She has a great surgeon, and so she won't lose her leg.
Good.
Okay, so back to my other question I wanted to ask you just along those lines, and you had touched on it, and I just want to drive it home as kind of we have just a couple more questions here, but I want to drive this one home first. So there are therapeutic reasons why you might need an amputation. So, you're in a situation and you have wounds that won't heal, and it might be a revolving door of treatment, and it's going to be changing of your dressings twice a week. And there's still always that risk in taking that approach. There's a long recovery, and there's the risk of course, sepsis, right? It could go from limb threatening to life threatening very quick if the infection gets worse and takes hold. You have that one option, right? And then you have the other option where, what, we can just take the leg now. And yes, there's a higher risk of morbidity, of course, with a major amputation, but you kind of have it either way. But if you can get the BKA or the AK, whatever it might be, or the TMA, the transmetatarsal of just the toes, get a prosthetic, get out walking. If you have all your ducks in a row and you have the entire care circle involved, ready to act and get you on your feet in 6 to 8 weeks, then that might be a way to go to get people back on their feet sooner and getting back to living life, even if it's in a new way, versus being stuck in their house worrying about wounds.
And not only that, being in pain all the time.
That's true too.
One of the biggest reasons for poor quality of life is pain. And it's a completely different discussion. And PAD is a very common problem. A lot of people have it, but every good surgeon or practitioner will tell you that it's not the same thing does not work for everybody. It has to be a tailored treatment for patients. Like you just described, if I had somebody who was a very overweight patient, I will keep trying to open them up, because for them to get up and start walking with a prosthetic in 6 to 8 weeks is almost impossible. For them, it takes more than time. If a patient is not overweight, they can very easily go through the scenario that you described and be very well. And, with months may even forget that they have an amputation. They get so used to walking around with it. But it has to be tailored. for every single patient.
Yeah. I think it's so important that there is a conversation. My biggest pet peeve, though, is when a doctor says it can't be done, it shouldn't be done, just because of their own personal beliefs, their own skill set, and they say it's not even worth treating. Why delay the inevitable? Go do it. Versus having a real candid discussion and finding out, how invested is the patient in time to be able to focus on that wound healing, and what is their entire care system, what does that look like for them to be able to do that, and take the time needed to heal some of those pretty bad wounds that we've seen out there, versus just going ahead and taking the leg and whatever. I just wish that the doctors would have a more understanding conversation. Like you're saying, everything is very well thought out, and it's a very patient-centric approach. It's an individualized approach. And I know there are a lot of people out there that are trying to put everything into algorithms and such. But what I've learned about PAD versus some of the other chronic illnesses out there is that PAD is so individual. I mean, I feel like every single patient, somehow there might be some similarities, but everyone seems to have their own story and presentation and need to have a very customized approach to their care.
Oh, absolutely. If anybody is a practitioner of PAD, they understand that it has to be a completely customized approach.
Yep.
We have tools. Sometimes the tools are used as, step one is something different, step two is something different for different people. Some people who I see the first time and I tell them there's going to be no wire, balloon, and catheter in your life. We're going to go for a bypass as soon as possible. And that the idea is not doing one thing versus the other, or a smaller thing versus a bigger thing. The idea is to get them out of pain as possible for as long as possible.
Yes. So we have two more questions here, and then I have just my final questions I ask every single doctor. I'm not going to pronounce this
My
right.
last thing is I have a hard stop at 6:30, so we gotta end at that time if
Perfect.
possible.
Yep, we're good. Do you know anything about cannabinoid hyperemesis syndrome? This is from Marcia. I don't know what that is, and I can't even pronounce it.
I also do not know what that is.
Okay.
It sounds like something with cannabis and heparin, but I will read about it. I don't know anything.
Okay. And then Heinz has one more question. Heinz, go ahead and unmute.
Hello again, doctor. Question then related back to the plaques that people get in their arteries. Have you noticed anything different when you see radiation-induced plaque?
Oh, that is completely different. Radiation plaque is completely different, and it's mostly very, very rubbery. The arterial wall also gets very rubbery in radiation. That's actually radiation. It's called radiation arteritis. It's a different disease almost than peripheral arterial disease. They have some similar symptoms, but the reason for the symptoms are different. I have two patients who have had radiation in their thigh, and in both of them, everything that I did with ballooning and everything failed very quickly. The only thing that worked in them is when I did a bypass from above the abnormal artery to below the abnormal artery.
Okay.
So basically a plumbing job from normal vessel to normal vessel and left the radiation artery completely out.
I'm a lucky one then. I haven't had bypass yet, but I have radiation in my thigh also. I have stents.
Oh, that's good.
Yeah.
And they're
I was
working?
just curious that what you see in that.
Yeah.
Heinz,
It's
are
more
they
rubbery
covered
than not.
stents?
I don't know. Whatever the stents, you know who my doctor is, Dr. Aaron, what he put in there. He uses state-of-the-art stuff. I can't think of the name. Supera stent? Is that covered? I think it's covered.
Oh, Supera is not covered.
Oh, it's not covered. Okay.
That's interesting. That was actually the most complete conversation I think that you've had in that answer, Heinz, to your question.
Exactly, 100%. Thank you very much.
That was brilliant. I think I'm going to save that one. That is amazing. We appreciate you on that, Dr. Lum. I'm just wondering, like in that situation, if covered stents could be used in those situations prior to, as long as they don't cut off the ability or for a doctor to have a clear landing zone in case that fails and bypass is needed.
I am not sure. My bias is, and it's my bias, that radiation, I like to do bypasses from
Yeah,
normal artery to normal artery.
that makes sense.
But
It really makes sense.
yeah,
And those
Supera is a
were,
good stent. Go ahead.
that's great. So we have just a few questions that we ask every doctor. I think I
Mhm.
might use your case that you used earlier, but I thought I'd give you a chance to come up with something new. So
Okay.
this is our segment sponsored by Reflow, and it's called The Pulse. And it's actually geared more towards doctors and clinicians, but patients are listening to it. So if you can also just keep that in mind as you're, to break things down in case they're needed. Um, Talk about a case. It could be any case. It could be a successful case. It could be a case that failed, but a case in which you learned something from that case that maybe others could learn from as well. Are we
You know
talking about
that
every case here?
No, 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 no. The reason I started laughing is because uh, let's talk about the case of a person that both you and I. Um, this patient suffered, I think, for about 9, 10 years, and she was very young when they started doing things to her. Right? They did a bypass from one side to the other, which is called a bypass. That failed. Then they did another one of the same things. That failed. Then they did a bypass from her aorta to her brain. That failed. Then they put stents in her iliac arteries to connect the aorta to the femoral. That failed. And then they tried to open everything with wires, balloons, and catheters. And I spent about 20 to 30 hours with her CT scan without exaggeration. And I looked at her CT scan as much as I could, and I tried to figure out what's going on. And I'll tell you, she had a very, very simple problem. Her simple problem was all the bypasses and the stents that I described were all going to the left common femoral artery, which is the artery in the groin. And her common femoral artery was just exhausted. It on the CT scan, it looked like someone sucked the life out of it. So I talked to some of my mentors who were like all in their 70s and they're all retired now. And I sat down and I showed them the CT scan on the video, and they all agreed with what my uh, theory was. And my theory was that the only thing I need to do for is replace the common femoral artery and open up the stents that they have put in her. And I did it, and it worked for 4 months. Prior to that, she was getting surgery every, like it. You could count it in a matter of weeks instead of months and years. And I think for me, uh, the learning point is as soon as you get a tough case, don't try to find easy solution. Try to look at the tough case. And I have a lot of respect for everyone who does this. And if somebody is failing multiple times, there has to be a reason. There's something that people are missing. And it worked out. And I'm going to do something similar again because we need to get it done. But that is one of the learning experiences that comes to my mind right now.
That's brilliant the way you explained it. And it's so important. And this is why I tell people always get a second opinion, get us another set of eyes to look at your case, because you never know when someone just has a different perspective, an outside perspective. Sometimes when people are kind of immersed in your situation, you need that outside bird's eye point of view to be able to look at things differently and create the change that you may need to see for a longer lasting impact. So thank you so much for that. Okay. This one you're gonna love. I can't wait to hear this one from you. So
Okay.
our next series that we're doing with Reflow is called The 6 Minutes That Matter. It stems from when I was at Forbes magazine. We had a series, The 10 Minutes That Mattered, where we would ask executives about that defining moment in their career or their life that led them to where, like, they wouldn't be where they are today, or they wouldn't be doing something that they're doing today if it weren't for that situation. It could be a conversation, it could have been a movie they watched, a scene in a movie, a quote, it could have been a particular case, whatever it might be, a gift that they received. But can you share a defining moment for you? And I can share a couple if you don't have any ideas, but um, let me know.
Well, maybe you should share a few because
Okay.
I don't. Go ahead.
So we had, for example, we had Dr. Mahmoud Razave down in Southern California. He's an interventional radiologist, and he said that when his mentor said to him one day that if the contrast fluid can get through, so can you, it changed his entire way of treating patients. It would give him, he would give the case a little bit more of the benefit of the doubt that he could get through and save the leg versus just sending them off to amputation. Another one was a doctor out of Germany that was telling us, and this was really cool, that he was in general cardiology and his wife was getting ready to have a baby. And once she had the child, she noticed that he just wasn't quite happy. I mean, as much as he was happy with the family, he just wasn't happy going to work every single day. And so she had this conversation with him one day and said, "What is it that would make you happy? I know you're happy with the family. I know you're happy with the child and me and everything else, but what would make you happiest at work? Whatever you need to make you happy is important to me." And he decided that he wanted to pursue angiography. And over there in Germany, they actually have an entire certification for just to become an angiologist. So I think that's what it's called. And so he did. And ultimately, he became so happy. He loved opening up arteries. And just in the past year, he became our global interventional cardiologist of the year. And so he was like, it was just cool to look back and realize that that was the defining moment that led him to where he is today.
I it reminds me of something. I was not like the IR guy. I always had confidence in myself that if there's something to be open, I can open it up. So that that was not an issue for me. But I'll tell you, the defining moment for me actually came from a breast surgeon in my general surgery rotation. Somehow, even now, I can hear her in my ear. And every time I come to a problem in surgery, or in doing what I do on a daily basis, I remember what she said to me. And she said to me, slow down. And her name was Dr. Polikoff, and she was less than half my size, but she was a brilliant surgeon. And she told me to slow down your hand, slow down your mind, slow down everything, and things will work out. And I still hear her voice in my ear every single time. And I think it was her. This happened in my second year, actually. And she is the reason why I was so successful in general surgery and later on in fellowship and now in my career. I still hear her voice in my head.
I love
Well, in
that.
my
That
ear,
was
I guess.
beautiful. Thank you so much, Dr. Alam. We really, really appreciate you. Dr. Syed Alam is in Battle Creek, Michigan. What are the other cities in which you practice?
So I practice in Kalamazoo, Battle Creek, Coldwater, Sturgis, Marshall, Hillsdale.
Fantastic. Thank you so
Yeah.
much, Dr. Alam. We really appreciate you. We appreciate everyone tuning in. We do have doctors every week that come in and answer your questions. So make sure to like this video, subscribe to our channel here on YouTube, youtube.com/at the way to my heart, and you will get notified when great content like this is showing up. Any final words, Dr. Alam?
No, thank you very much. It was great talking to you guys. So hopefully we'll be able to do this again.